All right, Chapter 16, Gastrointestinal Disorders. So in this chapter, disclosure statement. I don't own this material under fair use and providing lecture content only for my nursing students using this material. All content is for educational purposes and not provide medical advice. So this chapter, we're talking about the abdomen and the organs of the abdomen. So components of an abdominal exam. Identify important questions to ask when taking a history about GI problems. Identifying, describing GI disease that's associated with the esophagus. Identify and describe GI diseases that present with abdominal pain. GI disorders associated with regurgitation and vomiting, and then GI disorders related with constipation. GI problems manifested by the anterior abdominal wall defect. GI disorders associated with the liver, pancreas, and gallbladder. And then GI disorders associated with nutrition problems. All right, so first and foremost, go back over your GI, right? So the anatomy and physiology of the GI tract is the esophagus, the stomach, the small and large intestines, the liver, the gallbladder, bile ducts, and pancreas. So this child with any problems in this area would be seen by a gastroenterologist. So history taking with these patients, what's the problem? How long has the child had this problem? Weight loss, weight gain, history of previous illness. Have they traveled outside the country? Just think GI bugs. Sanitation in other countries may not be the best. So a lot of GI issues come from traveling in foreign countries. You not being used to those kind of bugs. The people there are fine because they're used to those bugs being in their system. But a lot of travelers have traveling problems. So ask the child or ask if the child is having abdominal pain. How often does the pain occur? Where's the pain located? Anything that helps the pain? Anything that makes it worse? Does the pain improve with defecating? Does the pain improve with eating? So you're trying to rule out different scenarios there with ulcers, duodenal ulcer versus other kinds of ulcers. So when you're thinking about ulcer, if you can find the Picmonic video about the GI tract in adults, it's very helpful to bring together all the different GI issues as well as GERD, all of those problems. So normal stool pattern, is it hard, is it soft, is it small, is it hard, is it watery? Do they have a ritual before stooling? Are they willing to go on the toilet? Do they hide? Do they block the toilet after the child goes? How often is the diarrhea? Is it watery? Does it have bits of undigested food in it? Is it explosive diarrhea? Is it cramping? Is it bloating? So does the patient have vomiting? How often does it occur? Is there nausea, cramping, headache, fever? Did the child feel better after vomiting? What's been done for the vomiting? Anything like that. What does the child normally eat? Are they eating out of pattern? Are they refusing bottle, breast? Reviewing the family history of GI for recent problems. Maybe it's a household thing. And then see if there's any problems in the family genetically as well. Social history, any problems at home, any new stressors, because stress leads to ulcers as well as other issues like diarrhea from stress. So when you're doing an abdominal exam, remember that we inspect, auscultate, percuss, then palpate. So when we're inspecting the abdomen, is it scaphoid? Is it very flat in a newborn? Are there missing portions of the GI tract? Marked distension with shiny appearance could be caused by air, fluid, or solid tissue enlargement. Is it flatter in older children? Should be. Prominent in newborns? A little pot belly? So you're looking for distraction during the exam because this is going to be in a sensitive area. Infants can be on breast or using a pacifier during that time. Toddlers might be reluctant to leave parents. Preschoolers might want to know what's happening and ask a lot of questions. And then school age and adolescent are more cooperative, but they need an explanation of what's going to happen next. When you're auscultating sounds for normal peristalsis. Vowel sounds are recorded as present or absent. Vowel sounds in all four quadrants. Increased with sound. If they're hyperactive, might be gastroenteritis or lactose intolerant. If it's loud, tinkly rushes with obstructive process. Absence after 5 minutes indicates a paralytic ileus. So auscultation of the infant's abdomen is easier if the baby's sucking and quiet. Preschoolers, school age, might want to also listen in your stethoscope. And then when you percuss, you're looking for a distension of the liver and the spleen size. Tympanic sounds are gassy, dull sounds filled with fluid. And then palpation, they should be supine, relaxed, arms at their side with their knees flexed. And make sure your hands are warm. Avoid tickling them and poking them. Use light palpation to decrease pain. Have them place their hand on top of the examiner's hand will help them feel some sort of control during this. So check for a hernia. Check perianal area for fissures, fistulas, or skin tags. Any muscle guarding, localized tenderness. Flank on each side for pain. So flank pain sometimes can be more indicative of kidney issues. Cleft lip and palate. So we talked about that in chapter 7. Cleft lip and palate questions tend to sound like, don't disrupt the new lip or palate with pacifiers, bottles, nipples, those kind of things. We might have to cup feed the baby. No popsicle sticks, anything like that would disrupt. So tracheoesophageal fistula is a hole or a tract between those two that are supposed to be separate tubes. This comes with kids that are polyhydramnios in utero. So when mom has lots of fluid, too much so. So think about the baby is peeing and drinking and peeing and drinking and peeing and drinking. Here's a problem. If the increase in fluid is happening, are they able to get the food down to the belly? So inability to handle secretions. They'll have an abundance of secretions. They'll turn cyanotic with feeding. We could not pass a feeding tube. It'll come right back up at us. So that's sometimes the first thing that we do if we think that this is happening. We'll put down a feeding tube and it'll come right back up. So there's 5 types of TEFs. The most common configuration is esophageal atresia. with a distant teph, and proximal esophagus ends blindly in the upper metastasin. The distal esophagus is connected to the trunk, the tracheobronchial tree. Second most common is esophageal with no teph, so it has a small stomach with gasless abdomen. So you can see those pictures on 362 in the book. So coiling of a feeding tube on x-ray, bowel gas pattern abnormal, ultrasound of the renal system, echocardiogram, and contrast evaluation of the fistula. So you can see the different types of esophageal atresia that's going on in here. So again, weight loss would occur because the baby's not actually getting fed. In fact, they may turn blue because the food's going down the trachea. So these are all different types of tracheal fistulas. So if the food's even getting to the belly. So they're probably going to go in, do a reconnection surgery on these children, surgical repair, right? So TEF is emergency care, hospital care, chronic care, and you're just preventing aspiration. A tube should be placed in the proximal pouch until surgery. IV access, fluid, antibiotics, supine position with the head elevated. Just think like a reflux patient. Oxygen if needed. Surgical repair will be indicated. We could tube feed them through their belly. If their belly is intact, we'll just go ahead and put in a Mickey, like as a G-tube. Chest tube care, continue antibiotics, frequently suctioning them. The head of the bed has to be at 30 to 45 degrees, just like any tube feeder. And then 2 to 3 days after surgery, we can start tube feeding them. Proton pump inhibitors, and then if there's no leak, they'll start oral feedings. Most babies are fine with this, don't have a problem. It's just us recognizing that that is the problem quickly before the baby dies of aspiration pneumonia. So we could have leaks, we could have stricture. They might have to put down the balloon to open up the stricture if a stricture occurs. So emergency care for this kid is provide IV fluids, diagnostic tests, explain operative procedures, provide emotional support. Non-nutritive sucking, all away. Give it to them. Because if you don't give them a pacifier while they're not eating, they will not know and they will have oral aversion. You don't want that. So we may go ahead and give IV and antibiotics to this patient IV to replace all those losses. Antibiotics because of the bacteria that now are in their lungs from choking down that food in their lungs instead of their belly. Caregiver can assist with oral feedings once the child has approved, once we know that everything is okay. But they can still hold the baby, touch the baby, stroke the baby. Definitely teaching them before they go home. Caregiver is going to need instructions on gastroreflux, big time. Disengagement cues, things like that, because the baby won't be breastfed or bottle fed. They'll be tube fed, but they should be doing the same things with the baby. And then some problems manifested by abdominal pain. Celiac disease is the big one. Celiac disease is an immune-mediated response to the ingestion of wheat and other proteolamines in genetically susceptible people. So when you talk about this, I want you to remember the brow diet. So feel your eyebrow and remember brow, bread, barley, rye, wheat, oats. So they cannot eat gluten, which is a protein found in oats, wheat, rye, and barley. Celiac disease is hereditary, so you're looking for family history. Manifestation usually begins after 6 months when you start including these things in the diet, like Cheerios and things like that. So you look for things like abdominal bloating, diarrhea, vomiting, weight loss, flatulence, like really foul smelling, delayed growth and development, dental enamel defects, and can have blistering pruritic rash on the elbows, knees, and buttocks. It's more common in adults, but it can occur in kids. And then from this, you're going to have iron deficiency anemia, B12 deficiency, and osteoporosis due to the calcium malabsorption. So celiac disease is recognized in 1 in 141 patients. So people with a first-degree relative, the rate's 1 in 22. So look for family history. So we do CBC, IgA, vitamin B12, ferritin, iron, folate, stool for occult blood, and you're doing an endoscopy. So if you look at page 364 in your book, there's diseases associated with celiac disease. So the way that they would sort this out, treat with a gluten-free diet, and then see what happens after you do the gluten-free diet. Addison's is not going to get better with a diet change. Immune system, liver failure is not going to get better with a diet change. Diabetic is not going to get better with a diet change. It might decrease their need for insulin, but it's not going to cure it. Rheumatoid arthritis is not going to get better, and autoimmune thyroid disease is not going to get better at that point. So when someone is having these issues, you're going to get IV hydration for the vomiting and the diarrhea, start gluten-free diet, endoscopy, discuss food likes and dislikes and teach them how to read labels for glutens. And then there's support groups as well. Overall, the education of the caregivers is going to be based on celiac crisis, extreme vomiting, diarrhea, dehydration. They need to come in and get IV and electrolyte replacements. Once they're on a gluten-free diet, they usually don't require the emergency care. We just have to get the parents to understand the diet and the restrictions. And then chronically, overall, you're just watching for adherence. Follow up with the gastroenteritis guy. Keep them going to support groups, camps, and stuff, because they'll be eating differently than other kids. They'll want the pizza, but they won't be able to have it. Appendicitis, you may or may not have had that as a child yourself, but the appendix is a finger-shaped pouch that's literally sitting down from your colon on your right side. So you just have to remember right side. So right where the ileocecal joint forms. So what's the goal of the appendix? The appendix is basically a filter in the trap, right? Like a filter in the drain of your kitchen sink. And it holds seeds, nuts, things that get stuck in it. So appendicitis usually sounds like initial pain in the periumbilical area, a low-grade fever, nausea and vomiting, not taking oral intake. They might have stool, but it might be present with diarrhea or pelvic pain, and they usually lay with their knees bent up. They'll have rebound tenderness in the right lower quadrant. If you press on the left and release it suddenly, the right side will hurt. So McBurney's point is the site of extreme sensitivity. So it's situated in the normal area of the appendix midway between the umbilicus and the anterior iliac crest of the right lower quadrant of the abdomen. If they internally rotate the thigh, it'll have pain. If you put passive extension on the right hip, they will have pain. They will have pain if you're jumping and landing on heels, and they will be painful for several days with a sudden resolution that may indicate perforation of the appendix. That's why we're not giving this kid pain medicine in the ER. Even though they're in pain, we're not giving it to them, because whenever they tell us, oh man, that's so much better, we rush them to the OR because they just perforated. So CBC is going to show elevated white blood cells, a shift to the left. Urinalysis, ultrasound, CT scan, think about pregnancy. We're looking for a ectopic pregnancy as well. CT scan, maybe. Most of the time it's just a hot appy. We're going to put this patient NPO because if there's a chance of surgery, we don't want anything down there. Monitor vital signs. Position the patient in a position of comfort. Give them IVs. Explain everything to the patient and the family. Prepare them for surgery. Pre-op teaching. And then after surgery, monitoring vital signs, IV therapy. You may have to give them antibiotics if it ruptured. Assess the pain with an appropriate pain scale, so FACES for kids 1 to 10. Encourage incentives barometer, ambulation, monitor incision sites. Traditionally, it would be an open appy. Now, they just have small incisions. It's laparoscopic more so now. Provide discharge instructions. And then if the appendix is ruptured, they may stay longer just because of peritonitis. IV therapy, NG tube, vital signs, labs, monitor drainage, change dressings. Acute appendicitis is now treated by laparoscopic removal. Remember, laparoscopic pain, some families have pain that's transmitted to the right shoulder or both shoulders. So again, discharge instructions would include limiting lifting and physical activity for a few weeks, and then the importance of medication administration after a ruptured appy. Looking for signs and symptoms of infection like RETA, redness, erythema, discharge, approximation. Okay. An inguinal hernia is a protrusion of the contents through a defect or an opening. So hernia is defined by its type. The inguinal canal would be an inguinal hernia, a lump in the groin, commonly on the right side. Again, if it is able to be pushed back in, it's not a surgical emergency. History of intermittent pain, swelling in the groin, weakness, pressure in the groin, a burning, gurgling feeling at the bulge. And then anyone with hydrocele, water on the sac, should be checked for an inguinal hernia. So here's the thing, incarceration and strangulation are the problem. If it's reducible, leave it alone. If it's incarcerated, it could strangulate. If it's strangulated, you're going to have an issue because the stuff strangulated is about to rupture. So emergency care would be starting IV fluids, prepare the patient for surgery, witness informed consent if they are incarcerated. IV fluids if not emergent, pain meds, non-nutritive sucking for infants. Keep the suture line dry and clean. If they are not toilet trained, you'd have to frequently diaper change and assess circulation on the side of incision. Again, once it's repaired, they shouldn't have problems. On the opposite side, we'll need periodic examinations. Umbilical hernias are most common in newborns, but they spontaneously close at 1 year of age if it's coming through the belly button. So the emergency care, just providing diagnostic tests preoperative, teaching if we do have to operate. Otherwise, it's teaching them how to reduce. Okay. Inflammatory disease. So Crohn's disease follows some following presentation, like abdominal pain in the right lower quadrant, mimics appendicitis. So Crohn's disease is redness, swelling, and pain in the GI tract. It can occur from the mouth to the anus, but it's more commonly found at the end of the small intestine and extend through the bowel wall. Fever, diarrhea, nausea, vomiting, anorexia. I want to point out that anorexia is not anorexia nervosa. Anorexia, the word anorexia, means not being able to eat or not feeling like having to eat. So don't look at that word and assume that it's an eating disorder. Weight loss, fatigue, anemia, delayed growth and development, could have canker sores, intestinal blockage, fistula formation. So we're doing CBC, electrolytes, liver panel, urinalysis, protein, albumin. You're looking for anything else, right? Stool for occult blood, ova and parasites, stool culture, inflammatory bowel disease panel, an upper GI series, a CAT scan, a colonoscopy, workup to rule out everything else. In the emergency period, you're going to take care of the abdominal bleeding. If there's bleeding, we might have to replace blood. IV therapy, and then high-dose corticosteroids. Corticosteroids help us with major flare-ups. Think about prednisone as being an anti-inflammatory corticosteroid. So IV therapy for hydration, antibiotics, Flagyl. Just consider Flagyl like anything fungal gets Flagyl. And then Cipro. May require surgery if it's that bad. Antibiotics might be sent home. Immunosuppressants, tumor necrosis factor blocker. That maintenance dosing every 6 to 8 weeks. Nutritional supplementation, protein shakes. And then just working with them about dietary issues, likes, dislikes. They're going to want to eat that pizza just as much as anybody else, that salad just as much as anybody else, but they may not be able to anymore. Support groups are great, right? Ulcerative colitis. So this is an inflammation in ulcers that formed in the large intestines. And it's usually the sigmoid. The rectum can be affected. The whole colon can be affected. That's why it's colitis. So that's abdominal pain, bloody diarrhea, streaks of blood, urgency to defecate, anemia, weight loss, loss of appetite, again, joint pain, skin lesions, bleeding. Okay. So it's inflammatory bowel disease, growth failure, potentially. So you're doing the same workup, your C. diff, your CBC, the lights, the enzymes, sed rate, albumin, prealbumin, protein, colonoscopy. And with this one, it's again IV therapy and antibiotics. IV for hydration, corticosteroid for getting them back into remission, and then your flagyl and other antibiotics, antidiarrheals as well. So caregiver might need to bring them in for signs of bleeding or pain. And then discussing feelings with the patient about being different. Have them do stress reduction techniques like visualization and relaxation. This can come bear its ugly head during tests and things like that. So if you're a nervous test taker, it might be more than just in your head. It might be in your gut as well. Peptic ulcer disease are open sores in the inside lining of the stomach and upper portion of the small intestine. The most common symptom is stomach pain. Peptic ulcers are basically two different types, gastric or duodenal. Gastric occurs on the inside of the stomach, and duodenal occurs in the upper portion of the small intestine. Most commonly, this is caused by H. pylori. Think about when we talk about long-term use of aspirin and other painkillers like ibuprofen, naproxen. This is what we're talking about. Can cause stomach ulcers. This is what we're talking about. Stress, spicy foods don't cause peptic ulcers. They can make the symptoms worse. So gastritis, just abdominal pain, anorexia, nausea, vomiting, decreased growth, recurrent stomach pain, episodic epigastric pain, vomiting that's not recurrent, being awakened at night, and anemia. So just consider it kind of like reflux, but it's an ulcer in those areas. So it could have life-threatening GI bleeding, could perforate the stomach, and could induce shock. So if these ulcers open up, a lot of the time they're bleeding ulcers until they open up and now they're dumping into the abdomen. Peptic ulcer. So some of the forms of stool that you need to know, like if stool is black, it's usually a requirement that you test it for blood because it's probably old blood. If blood is in the stool, it's usually after the digestive system. If there's black stool, it's usually above the digestive system because the blood has been digested. Melena, look it up, a type of stool. The current jelly, a type of stool. They're all some form of issue, right? So typically if we see clay-colored stools, it's a gallbladder issue because the color of green, brown in your poop comes from the bile. So the diagnostic texting again for an ulcer, CBC, sed rate, see how we're doing with the bleeding, an upper GI series, endoscopy, H. pylori tests, H. pylori tests from the antibody blood tests, and also the stool. So we teach parents that in emergency care, they need to be seen immediately if there's sudden persistent stomach pain, bloody or black stools, vomiting blood or coffee grounds, and they need to be kept NPO and given IV therapy. We may have to give a blood transfusion in the meantime. So usually, if you're having H. pylori, there's going to be a mix of 3 drugs that is going to be given, and they have to be taken in their entirety to treat the H. pylori. So triple therapy usually consists of 2 antibiotics, most often amoxicillin and flagyl, and then also a proton pump inhibitor, something ending in prazole. So proprantazole, omdazole, whatever. So then the teaching is medication compliance, patient compliance, and then telling them that there's a vaccine currently under investigation for H. pylori. Avoid all NSAIDs, good hand hygiene. Um, a lot of education around stress reduction, the importance of med compliance, and you're looking for medication side effects and things like that. So just the importance of the follow-up care, the avoidance of foods that may aggravate, encourage normal sleep and normal activity patterns. And then your IBS. Your IBS is a clinical presentation of cramping, bloating, and diarrhea. Most of the time it's the large intestine, the colon. And even though symptoms are uncomfortable, it doesn't always change bowel tissue or increase the risk of colorectal cancer. So a lot of the times in GI diseases, you can see on table 16.1, the normal drugs, you may just want to once those over. There's a good chance those medications are in there. You'll remember them from pharmacology. So famotidine, obviously Pepsid. You've probably already heard those. Proprantazole, Reglan, lactulose for chronic constipation, mineral oil for constipation, ducosate sodium senna is a natural remedy, and bisacodyl. So either too hard or too loose, we get a drug for that. IBS is more common in women than men. It can be a change in the appearance, either loose or hard, thin or like pellets, and mucus in the stool. It can be associated with other pain symptoms, like chronic fatigue and fibromyalgia. So a lot of the times diagnosis is established by the history. You still want to do your CBC stool sample for occult and parasites, ova and parasites in occult blood, stool sample, stool culture, and endoscopy. This one, usually the pain is much better after they have a bowel movement. So you're stressing to them not to eat large meals and avoid trigger foods. So 6 small meals a day is always the answer on the test. Monitor medication effects, side effects, and then chronically you're just talking to them about avoiding fatty foods, dairy, carbonated beverages, caffeine, and keep a diary of symptoms. Increase high fiber foods, several small meals, drink plenty of fluids, fiber, laxatives if needed, and Imodium for the diarrhea. Probiotics is one of those things that comes up in this as well. Probiotics have demonstrated a decrease in the amount and duration of diarrhea. A short course for more than 2 days might be beneficial. So probiotics demonstrated a decrease in the frequency of pain and pain intensity. They have also shown promise in adjunct therapy for Crohn's disease and ulcerative colitis. So currently in pediatrics, there's ongoing studies, but no current recommendation. So symptom management, avoiding foods that trigger. Teach the use of the diet because the child is without the parent for some part of the day. Fish oil capsules could also be used as well. And now we will move into the vomiting issues. So two big ones, reflux and pyloric stenosis. So regurgitation, usually what we talk about is how much food did they throw up? And it's usually breast milk early in life. So all babies spit up, some more so than others, but approximately 50% of 4-year-olds, 4-month-olds are going to regurgitate, approximately 20%. So some kids are going to show up. For the reflux, we tend to say go ahead and put rice cereal in their formula just to make it way heavier in their stomach so it doesn't come up in reflux. So it's normal for gastroreflux because of the immaturity of the lower esophageal sphincter to actually close. And so it sometimes tends to relax, which causes that retrograde flow into the esophagus. So we have to kind of run through a different disease process, right? Is it celiac? Is it irritable bowel? Is it Crohn's disease? Is it lactose intolerance? Is it constipation? Is it gallbladder issue, small bowel, or is it failure to thrive? If it's failure to thrive, that's one thing. Failure to thrive, you just add extra calories, like instant breakfast or whole milk, protein shakes, things like that. Reflux is unpleasant, it hurts, there's a small amount of fluid. In silent GERD, the milk actually enters the esophagus, causing burning, coughing, and choking. So does the baby cough 30 minutes after you put them down? Could be weight gain or no weight gain associated to the pain. Irritability, crying, especially after meals, arching their back. They may present with apnea as newborns. A child with a chronic cough, that's a key indicator for you. Chronic cough, children who sleep and then wake up coughing. Children might have pain in the epigastric area, mid-sternal discomfort, sleep interruption, persistent throat soreness, but they're not sick. So we do occult blood, rule that out. pH probe could happen. They put the pH probe down your nose into your stomach and watch you for 24 hours. We might do a gastric emptying study, esophagram. So the big thing with this is to make sure that the parents know CPR in case the child stops breathing. Monitor INO, weight. Look at feeding style. Could have Reglan. Proton pump inhibitors. On the proton pump inhibitors, Prevacid, things like that, could be opened and sprinkled on food. If it's truly severe, we could do a niacin fundoplication. So look that one up. It's where they take part of the esophagus and wrap it around. So monitor INO, including NG tube secretions, if you put an NG tube down these children. Continue to breastfeed. Medications, stress avoidance of foods that trigger. Reduction of weight in obese. And then most of the time it's fatty foods and acidic foods. So citrus juices, carbonated beverages, and tomato products. Stay away from those. Red sauce, pasta sauce, is a common problem. So we could change the formula eventually. Frequent burping, upright positioning, keep them in their car seat or carrier after feeding. Make sure that that medication gets given 30 minutes before the feeding. So again, for older kids, it's going to sound just like an adult, right? No eating or drinking 2 hours before bedtime. Avoid caffeine, chocolate, spicy, fatty, and acidic foods, carbonated beverages. Avoid cigarette smoke, weight loss, and a PPI 30 minutes before breakfast. A low fiber diet might help reduce reflux. And then your pyloric stenosis. The pyloric stenosis is where the pylorus blocks food from entering into the small intestine. So it's stenosed down on the bottom of the stomach, where the pyloric valve opens and shuts to let food out. So the pyloric stenosis, the muscle thickens and becomes abnormally large, blocking food from reaching. So could we go down there with a balloon and open it up? Yeah. That's usually the situation that we're in. Found more common in boys than girls. Higher incidence if the mom had the disease. Its key, and this will be on the test, is forceful, progressive, non-bilious vomiting after every feed. It's non-bilious, okay? So it's not green, it's just the milk coming back up. Onset of vomiting from the first week of life to as late as 5 months of age. The vomiting becomes projectile over time, and it happens in peristaltic waves. Okay, so you can actually look at their baby's stomach, and there's waves happening from left to right before that vomiting occurs. Eventually, they'll be dehydrated and decrease in sodium and chloride. Poor weight gain, failure to thrive, metabolic alkalosis. Sometimes there's jaundice. So the pyloric mass, the olive sign, is important. If you see a pyloric mass happening in the middle of their belly, that's a good clue that that's happening. And then we do upper GI series, CBC electrolytes, liver panel, the whole workup. So this kid needs to remain NPO with a pacifier for comfort. Isotonic solution, electrolytes is needed, so sodium chloride. And then teach caregivers about diagnostic tests that need to be performed. If they do have surgery to correct it, you're going to answer all questions, emotional support, provide a breast pump for moms that are breastfeeding. Keep pumping, keep pumping, keep pumping. We'll hold it. Appropriate pain medicine for the baby. Monitor incision site for infection. Keep the fold of the diaper low. I&O, daily weight, and advance their diet as tolerated. Super important to burp these babies. And then because we're in their stomach messing around, there's going to be a lot of edema in the area. So they could consistently vomit after for a couple of days. So you're telling them before they go home the emergency care. Persistent vomiting, lethargy, get in here. You're teaching them how to assist with feeds and get them able to take care of the patient before going home. Okay. Then we go into the things that are caused by intestinal obstruction. These are some of the fun ones. So intestinal obstruction prevents the normal movement of products of digestion. So it could be the small or it could be the large bowel. We're not sure. Sometimes it's both. But a clinical vomiting, a clinical judgment question in your book is the bilious vomiting. Bilious vomiting means that bile is in the emesis. So it's an ominous sign until proven otherwise. So anytime the bile is green, green stuff's coming out, it's always a problem. Okay, so let's get started with this. Volvus. So volvus happens when there's abnormal twisting of a portion of the GI tract. It's usually the intestine, but think about it. If we twist a piece of intestine and it's not getting blood, it's going to be gangrene and die, and then perforate, and peritonitis is going to happen. So the stomach, the small intestine, the cecum, and the sigmoid are all subject to volvus. That's a malrotation of bowel during fetal development. Could happen, and it usually has a sudden onset. So this could be in a baby. We've got to be aware of that. The cecum is usually not positioned correctly. The tissue that holds it in place crosses over and blocks part of the small bowel. That's malrotation. Okay, so you see that the small bowel is underneath the large bowel. The cecum isn't where it's supposed to be. Volvus occurs most often in the first 6 months with intense crying and pain, pulling up the legs to the abdomen, abdominal distension, bilious vomiting, tachycardia, and tachypnea. You're going to do an upper GI series, CBC with lights. You can imagine IV fluid, right? So emergency surgery. We need to get that counterclockwise. We might have to do a resection of the colon if we need to. So we might have to cut pieces of that away. So you see the portion of the intestine twists around itself. So keep them NPO, establish IV therapy, insert an NG tube, INO, prepare them for surgery, keep them with their pacifier. Emotional support for mom and dad, because this is a newborn. Use the neonatal pain scale. And then after surgery, you're monitoring the incision site, monitoring the NG tube, and then with the return of bowels sounds, then we can start feedings. This baby might be in the NICU if they didn't leave the hospital. But explain all procedures to the caregivers, answer all their questions, and let them hold and rock their baby. There's nothing wrong with letting them hold them. Non-nutritive sucking, again, with a passy. Keep their sucking reflex. Keep it going. Interoception occurs when a part of the intestine slides into an adjacent part. So it's a telescoping that can block food and fluid from passing through. It could also cut off the blood supply, which would lead to perforation, infection, and bowel death. And it's the most common cause of intestinal obstruction in kids younger than 3. Interoception usually is caused by Merkel's diverticulum, a polyp, or enlargement in lymph tissue. They suddenly draw up their legs, crying, possible vomiting, and then they're symptom-free. It occurs in regular intervals every 15 to 20 minutes, like the peristalsis that's occurring in this area. The vomiting will contain bile, and then after 12 hours of this, you're going to develop currant jelly stools, so stools that are a mix of blood and mucus. Currant red jelly stools are a key indicator that it's interoception every time. Bilious vomiting, volvus. Jelly stools, interoception. Fatty stools, cystic fibrosis. Almost every single time you can go with that. fever, peritoneal irritation with guarding and tenderness, tachycardia, WBCs. It's going to look like an infection because the tissues are dying while we're waiting here. So we can do a barium enema or an air enema with these children. It might work or it might not. It's usually an ultrasound waiting for the CBC to come back. But your emergency care is IV therapy. Almost every single time, do you see this? Most of the time you need IV therapy. The kid's going to be dehydrated. Keep the kid NPO. Establish IV therapy. INO, INO, INO. Provide them with a pacifier. Never not the answer, right? So a barium enema, an air enema, or a water-soluble solution could be used, but you still want to keep the kid NPO. And then after surgery, we'll get them back to regular feeding gradually. But you're going to maintain an NG tube, IV therapy, pain medicine until bowel sounds return. INO, INO, INO. So you're explaining procedures to the patient, the parent, giving the baby to the mom to hold and rock. Explain all procedures. Oral feedings, anything that we can get them to do, we do allow them to do. Even if it's a tube feeding, we'll just show them how to do that. So atresia means complete obstruction. Stenosis is an incomplete obstruction. Atresia occurs more often than stenosis, and it's usually with bilious vomiting, abdominal distension, failure to pass meconium, and jaundice. Okay? So now we get into necrotizing enterocolitis. So consider that we have more premature infants in the US now. So this is often going to occur in premature or chronically ill infants. This is tissue death of the intestine. Let's go back to where it comes from. What happens in premature infants is that they're not ready yet, so their belly's not ready yet. They don't have the gut bacteria that we need yet. So if we start feeding them too early, they end up having neck. There is a good chance a 32, 34, 36 weeker. 36, you're probably okay. 23, 24, 25, these kids have a greater chance to have neck. This is why there's an importance of having breast milk, even if it's donor breast milk, because cow's milk does not belong in a baby's stomach when they're premature. They're not ready yet for that hit. So, neck happens in premature infants, especially after an infection or an ischemic event. So think about those kids that we end up tubing, intubating, CPR, that 1% of kids. They're extremely delicate. So what you will see is, and this is why we do abdominal assessment before every feeding, because the first things you'll see is that the belly is getting bigger, that their belly starts blowing up. Their belly's blowing up because they have a necrotic intestine. So you're looking for a tense, distended abdomen. If they're distended abdomen, where do you think that's going? It's pushing up on their little lungs, and they're not going to be able to breathe. So a large gastric residual, greater than 2 cc's. So think about this when we do NG tube feedings and G tube feedings, right? Aren't we looking for a residual? It's a key indicator, if they still have residual, that their bowels are not moving. Stool positive for occult blood. Increased period of apnea, so your A and B's. Decreased blood pressure, and poor stability of temperature. Think about this like sepsis in a baby. and it's coming from their abdomen. If we catch it in time, they'll be okay. But a lot of these babies die. You get them from 23, 24 weeks all the way to 30, 32. The mom and the dad are thinking about going home, and then this happens. So if nurses are doing their assessments, if nurses are very astute to the changes in their baby, they'll be able to see these things, get a CBC, CRP, stool, abdominal x-ray, and you're always doing abdominal girths before every feeding. So you're going to keep this child NPO, rest the GI tract, maintain IV therapy. We are definitely going to give this kid total parental nutrition, TPN. Here's a caveat with that. TPN, we find in babies, especially in the NICU, tends to also lead to liver failure. So it's a double-edged sword. We don't want them on long-term parental nutrition. We don't want them on total parental nutrition very long. They may have to. Administer antibiotic therapy in case it does burst. And then surgical intervention is going to cause short bowel syndrome. So short bowel syndrome means that there's an alteration in the digestive and absorption process because there's not as much bowel material. So that can cause nutritional, metabolic, infectious consequences, a bowel obstruction. Okay. So small bowel, short bowel syndrome is a real thing in NICUs. We're looking at it all the time. We may end up having to give this kid an ostomy. So then they'll deal with the ostomy nurses as well. So that's why you really want to prefer breast milk over cow's milk. And a baby with short bowel is probably going to need long-term parental nutrition. But you also want to prepare the patients for the potential for a liver transplant. The goal of therapy is to advance them back to enteral feedings as quickly as possible. Liver failure is one of those reasons why TPN is used rarely in the NICU. So you're going to be doing a lot of explaining, answering a lot of questions, explaining procedures, but always encourage the parent to hold the baby. Do any oral feedings they can, non-nutritive sucking all the time, and provide her with a breast pump to keep pumping, because that breast milk is gold when we can get back up. Caregivers are going to be taught signs and symptoms of infection, and then if they have short bowel, they're going to know to avoid juice, soda. They're going to have to learn how to do enteral feedings. They will need to know about solids and meats first if possible. Protein is going to be more important to these kids. Could discuss parental long-term nutrition with a PEG tube or a G tube or a Mickey if the bowel is less than 40 centimeters. And then instructions on infection and complications all the time. All right, so neck is kind of one of those things you hold your breath and hope that nothing happens to that baby because we don't really want this as much as possible. Okay, gastroenteritis. So again, just like any other kid, right? Gastroenteritis, watery diarrhea, abdominal cramping, vomiting, headache, fever, chills over 102.5, stools with pus or blood. Dehydration sounds like depressed fontanelles, lack of tears, poor skin turgor, lethargy, right? So again, most of the time, this is not a big issue. It's a couple of days. We're all good. But it is a major source of morbidity and hospitalization in kids less than 5. Kids less than 5 don't have a lot of room for dehydration. So dehydration, first thing, IV therapy, isotonic solution. So we'll start right off with NS to fill the tank. and then electrolytes, and then we'll switch them over to D5 1/2 NS. There's always a metabolic risk of metabolic acidosis and hypovolemic shock. So those are the things you're looking for when the kid comes in and they're obviously dehydrated. You're looking for shock and eventual circulatory collapse. That's why a kid 3 days old in the waiting room needs to go to the back faster than a 5-year-old out in the waiting room. Think about age and the risk of dehydration. These kids don't have a lot of space. So severe diarrhea, vomiting, get an IV in them. Stool culture, antibiotics. If the patient's not rehydrated, care can be given at home. Withhold fluids for 2 to 3 hours. Start with 1 teaspoon of fluid every 15 minutes. At home, they could give Pedialyte, water, popsicles. You know the brat diet. So clear broth, saltines, and then if the patient stops to vomit. So if they're vomiting, stop everything, start all over again. If it's only diarrhea, take a brief period of rest from intake and then restart fluids. Moisturize lips with Vaseline as long as there's no oxygen in the environment. Allow pacifier. And then because of the diarrhea that's going to occur, just make sure you're using a good zinc oxide. Most of the time they return to a regular diet. In the second 24 hours. So again, fluids for recovery. Don't give antidiarrheals like Imodium or Pepto-Bismol to a baby. Pepto-Bismol has aspirin as a hidden ingredient, so we don't want that. So the brat is like bread, rye, rice, applesauce, dry toast, bananas, right? The brat diet. So bananas, plain rice, boiled potatoes, toast, crackers, cooked carrots, baked chicken without the skin. So the brat diet. Don't give unlimited fluid. They're going to vomit. Hand hygiene, hand hygiene, hand hygiene. All right, let's stop for a question. Which of the following are signs of necrotizing enterocolitis? We heard about that. We heard about that before. Definitely a tense, distended abdomen. Definitely gastric residual greater than 2 milliliters. And a stool positive for occult blood. Yeah. Poor temperature stability, decreased blood pressure, apnea, the whole deal. All right, constipation. The things that are manifested by constipation. Functional constipation. It's not typically caused by a serious disease. The most common constipation is functional or idiopathic, which means there's no sign of injury, infection, blood, abnormality, nothing. So functional constipation is infrequent stools, hard, small, pebble-like. They complain about pain when stooling. They're leaking stool between bowel movements. Holding, hiding, squeezing buttocks together. History of general stooling habits. Just get a good history on them. We could do an occult blood, a flat pate of the abdomen, barium enema. But more times than not, it's going to be just fine. So things that we can do with kids don't poop. Don't really want to do disinfection as much, but the need for extra fluid, the need for extra exercise, the need for extra fiber, right? Just like anything else with constipation. We could use Miralax Could use mineral oil, lactulose, a short-term couple day senna, Ducalox short-term. Enemas could be helpful short-term. Again, you don't want them hooked on this. The big thing is behavior modification. So regular times for stooling, especially after meals, 5-10 minutes, go to the bathroom. A reward chart. Eliminate cow's milk. That could be causing the problem. A lot of people sneak in prunes, a brown cow. So a kid should sit on the toilet after meals. Use a reward chart. Rewards could be not food related. So increase fruits and vegetables, fiber, exercise. Dietary therapy alone could be very helpful. And then your Hirschsprung's disease. Hirschsprung's disease is a congenital condition which causes a blockage in the intestine because of the lack of nerve involvement. So the nerves normally allow the muscles in the wall to contract and move digested material forward. It occurs 1 out of every 5,000 live births, and more often in males than females. So just so you know, this is always on the NCLEX because it's very rare, but when it does happen, it's truly a problem. Okay? So in your book on page 384, you can see the difference with a disease section and a normal section. So it's just the nerve cells didn't continue to develop in utero. There is a big indicator that the child has not had their first poop, right? So the failure to pass the meconium in the first 24 hours of life with increased abdominal distension is a great thought process. No meconium in the fluid, no bowel movement more than once a week, ribbon-like watery stools, vomiting, poor weight gain. If you do a rectal exam, the empty rectum, otherwise it'll be on your abdominal x-ray. Barium enema. So establish IV fluid, electrolyte, antibiotic therapy. If it's not an emergency, they might administer some enemas prior to surgery. Otherwise, just prepare the kid. IV therapy, NG tube, monitoring the operative site, the antibiotics. Observe for complications. You could do a warm saline irrigation of the rectum. And then chronic constipation impaction. Okay. Education, education, education. Follow-up appointments. Again, it's important to de-emphasize mealtime stress, like a fussy eater. Be active in their treatment. It's going to be treated similarly to chronic constipation. They're going to have issues. Okay. So, gastrointestinal problems with abdominal wall defects. I've talked about this from day one. So, when the baby gets handed to you, and you look down and there's an open sac of intestines sitting there for you, hopefully you are in the C-section room when this happens. And it's well known, and we knew about it. Because any pressure on the omphalocele or gastrosynesis is going to cause problems. So these two presentations are, you're handed a baby with an opening on the front of their belly. Omphalocele, the O tells you that the sac is intact. It could be anywhere from 4 to 12 centimeters and include the liver, the spleen, the gonads, and the bladder. The sac might rupture in utero or as it's coming out the vagina. And it's associated with anomalies like heart defects, neural tube defects, and also the bladder hanging out, called extrophy of the bladder. So gastrosynesis, the G tells you it's open. So this is the intestines being at risk for vascular compromise. Abdominal musculature completely open. And it's unusual to have any other abnormalities with these guys, but this is usually caught on ultrasound prior to the delivery if the mom is getting prenatal care. Emergency care upon delivery, you're putting down a G-tube down their oral gastric, right? So you put it down their mouth and in. That takes off the pressure of the stomach. You're doing IV insertion, respiratory support, and then you're wrapping the defect that you find, sterile normal saline, non-adherent dressing, under plastic. That keeps the opening warm, wet, and protected. So both of these, omphalocele or gastrosynesis, just like an opening on the back, you will cover it immediately with warm, sterile saline dressing and plastic wrap. We use a lot of plastic wrap in the NICU. So support IV fluid needs, closure of the defect, G-tube, OG-tube to decompress the intestines. They'll get parental nutrition, IV antibiotics, but we still want to give them a pacifier. And then after surgery, you're observing the surgical site, observing for their first poop, and then gradual resumption of breast milk. They could have TPN for several months. There's a slow increase in oral feedings and close monitoring. So in the point of these two things, omphalocele is going to be corrected more quickly than a gastrosynesis. An omphalocele needs to be covered back up, and it's primarily not as hard to put those organs back in. So an omphalocele will go right to surgery in 24 hours, 48 hours, once the child is stable. A gastrosynesis, on the other hand, is different. Those bowels usually get put in a silicone sleeve and hung above the baby, and with gravity they go back in over time. Then we finally close them up. So two completely different paths for these kids. A gastrosynesis may have the guts hanging from an IV pole above the child, so it's more trauma to the caregiver. But we want them to hold the patient, non-nutritive sucking, provide breast pump for mom, and then you're just doing infection control big time. They could be a more fussy eater. They could have oral aversion as well. Okay, so those are the fun ones. Find a good picture of that. And then your other things with the liver, the pancreas, and the gallbladder, again from adults, similar. The non-fatty alcohol disease, the cystic fibrosis we've talked about a little bit, cholecystitis, gallstones, and hepatitis. But neonatal jaundice is different. So neonatal jaundice is usually the breakdown of red blood cells and the immaturity of their liver. All those blood cells are going to the liver quickly, causing a yellow staining in their eyes. So again, every baby gets a test before they go home. We talk to them about severe jaundice. The concern is if the jaundice develops in the first 24 hours. And the higher risk for jaundice are the kids that are blood type Rh Coombs positive kids, and also anything with their blood type, right? So ABO incompatibility, Rh incompatibility. So we're doing a transcutaneous bili reading on every baby, and then we could do a serum bili as well. So at very high levels of jaundice, it's going to be lethargy, poor feeding, signs of infection, arched back. As soon as it hits the brain, it's going to occur with high-pitched screaming, cry, poor sucking, things like that. So kernicterus is the biggest issue. If you want to watch a video on that, just look up Sue Sheridan video online and you'll see all about that. So bilirubin results, if they're high enough, 20, we're going to go to the NICU and have phototherapy. If it's over 25, it could be that we have to send the baby to the NICU for exchange transfusions. So the biggest thing is jaundice in the first 24 hours needs to be put under bili light. IV fluids, eyes patched, scrotal area must be covered in males. It will make them go sterile. And then continue to breastfeed. So the exchange transfusion, O negative or typed blood would be used. Close monitoring and a bili blanket could be discharged home. Follow-up appointments. That's why we have them follow up in 3 days. If a baby is poorly feeding or sleeping a lot, they should be checked. Biliary atresia, so blockage in the bile duct. Again, significant jaundice at 2 weeks of age. Poor absorption of fat and fat-soluble vitamins A, D, E, and K. Dark urine. Light-colored stools. What did I say? Chalk-colored stools. Pale gray or white stools. The bile duct is closed. And then it backs up into the liver. So emergency IV fluid, diagnostic tests, reassurance, and then after surgery, just NG tube for decompression, abdominal girth every day, watching for bowel resumption. High protein, low fat diet, parental nutrition. Again, answer any caregiver questions. If a liver transplant occurs, that's a whole nother. And then your non-alcoholic fatty liver disease. You probably know that from med-surg. Cystic fibrosis, we've talked about, a hereditary disorder of the exocrine glands, thick mucus, blockage of pancreatic ducts, intestines, bronchi, and respiratory infection, usually caught with failure to thrive, chronic diarrhea, respiratory symptoms. Could be a meconium ileus, rectal prolapse, sternuria is the fat in the stool, pancreatitis, diabetes, slow poor growth. The sweat chloride test, we've talked about this, right? So this is a good review of this, but you've already had it. So again, teach childs that foods may be eaten without taking enzymes. Those foods include fruits, juice, soft drinks, sports drinks, tea, lollipops, fruit snacks, jelly beans, gums, or popsicles, freezer pops. Otherwise, they're eating their enzymes. So know your pancreatic enzymes for this chapter. Your vitamin A, D, E, K. So you've had this in respiratory chapter. And then your cholecystitis and gallstones, that's going to present very like an adult. Again, IV therapy, analgesics, antibiotics, prepare them for surgery, gallbladder removal. Again, most of the time we start with low-fat food. Hepatitis, usually a viral infection or liver damage, inflammation of the liver. So Hep A is fecal oral contamination. Hep B and C are blood products. Hep B may be spread to the mother to the infant during delivery. A, B, and C could be asymptomatic. So some symptoms: jaundice, pain in the right upper quadrant, dark urine, light-colored stools, petechiae, spider hemangiomas. Diagnostic testing, again, know how they're developed and transmitted. So again, vaccines for hepatitis A and B. You may have those already. And then, of course, your two issues with nutritional changes, either obesity or failure to thrive, right? So those are pretty easy. Trying to encourage weight control for babies and children versus your failure to thrive. So a failure to thrive is less than 5th percentile on those grids that we talked about. So lack of intake or need for immediate intake might require hospitalization. Suspect for child abuse, hospitalization. Again, just consider that might set us up for problems in the future as well with eating. All right, which statement is true? So if surface antigen is positive, the earliest indicator of active infection for Hep B, it's also present in chronic disease or carrier state and does not become positive after immunization. Okay, so in this chapter we did more about gastrointestinal problems. Awesome.